Yes, go ahead.
Oh, hi, everybody. It's good to see you. I'm sorry I couldn't be there in person. I'm in an airport, but I'm Rick Marlink, as probably most of you know, and just wanted to introduce our perspectives in global health equity seminar series. This is the latest in that installment, and I wanted to welcome everyone. And before Dr. Herrera introduces Professor British, I'll just say that we're happy to have this series where we have distinguished faculty visiting and talking about their work. And the common theme is that their work addresses key issues in health equity, whether it be in infectious disease solutions or any of the other areas that the Institute works in and focuses on. But again, thank you everyone for being here and being online. I know we have folks from other countries and some of our Impact Council here online. But welcome, and I'll let Bobby take over and introduce Carlos.
Wonderful. Well, hi, everyone. Thanks for joining in person as well as online. My name's Bobby Herrera. I'm an assistant professor at the Rutgers Global Health Institute, as well as the Department of Medicine, and I'm a resident scientist at the Child Health Institute of New Jersey. I did write speaker notes because I think Carlos is worthy and deserving of a really nice introduction. So just bear with me as I go through this. So good afternoon, everyone. It's my pleasure to introduce today's speaker, Dr. Carlos Brites. Dr. Brites is a professor of infectious diseases at the Federal University of Bahia in the beautiful Salvador, Brazil. He is internationally recognized for his contributions to the fields of HIV, HTLV-1, and viral co-infections, and has dedicated his career to understanding how chronic viral infections shape immune function, disease progression, and long-term clinical outcomes. Among his many accomplishments as a physician scientist, Dr. Brites has made major contributions to our understanding of HIV and HTLV-1 co-infection, immune activation, retroviral pathogenesis, and antiretroviral therapy. His work has helped define how HTLV-1 alters HIV disease progression and inflammation, particularly in regions where both viruses are endemic. What makes Dr. Brites particularly unique is that he bridges basic science, translational research, and clinical medicine. In addition to leading an internationally recognized research program, he oversees one of the largest HIV clinical programs in Brazil, providing care to approximately 4,000 patients. His combination of scientific rigor and extensive clinical experience give him a unique perspective on the real-world challenges faced by patients living with chronic viral infections. Perhaps one of his most important and enduring contributions has been his commitment to improving outcomes for individuals living with HTLV. HTLV remains one of the most neglected human retroviruses, affecting millions worldwide and serving as a cause of devastating diseases, including adult T-cell leukemia lymphoma and HTLV-1 associated myelopathy, also known as tropical spastic paraparesis. Despite decades of research, effective therapies remain limited for HTLV-1. Dr. Brites has been at the forefront of efforts to better understand HTLV-1 pathogenesis and, importantly, to identify therapeutic strategies that can improve the lives of affected patients. Today, he will discuss these challenges and opportunities in his seminar titled HTLV-1 Co-Infections and the Quest for Effective Treatment. So please join me in welcoming our distinguished speaker, Dr. Carlos Brites.
Good afternoon, everyone. Thank you, Bobby, for your kind introduction. I am pleased to be here, and it's a great honor. And I'm grateful for Bobby, Arnold, Keith, and Rick for the warm welcome. Well, so in the next few minutes, I try to summarize some data, share with you some of the results we have found during our studies on HTLV-1. As you probably know, HTLV-1 is a human retrovirus. It was discovered before HIV was. And we have today 4 types already identified, HTLV-1, 2, 3, and 4. The last 2 are restricted to Central Africa areas, rural areas, has no clinical significance. HTLV-1 was isolated from a patient from adult T-cell leukemia in Japan in 1980, and HTLV-2 was isolated 2 years later. When HIV was discovered by the same group, Gallo's group, they called it HTLV-3 because they believed that HIV was the third member of this group of retrovirus. And basically, from these four viruses, the only responsible for clinical manifestation of infection is HTLV-1. Well, a brief overview on epidemiology. There is a wide variation in the estimates of prevalence of HTLV-1 around the world. It varies from 5 to 20 million. The difference is because most of the studies were not properly adequate to measure the incidence or the prevalence of the infection. So we have many different numbers regarding the magnitude of the infection. Adult T-cell leukemia lymphoma is the maybe most severe manifestation of disease. It's a deadly disease and affects about 2 to 5% of the infected patients. Basically, those that were infected during the childhood or by vertical transmission or by parenteral, especially blood transfusion. A myelopathy associated with HTLV-1 affects about 0.5 to 0.3% of the patients, and this is a degenerative neurological disease that evolves during decades, sometimes during only a few years, and can restrict the patient to a wheelchair with many health problems that can decrease significantly the quality of life of this population. The transmission routes are the same we see in HIV, for instance, vertical, parenteral, and sexual. But in Japan, they believe that the vertical transmission is the main route of transmission. In our country, we believe that sexual transmission is the main route of transmission of the HTLV. Why the co-infections is a common? It's an obvious response because they share the same route of transmission. Okay? So where we have HIV and HTLV-1, we will find some patients co-infected by 2 or 3 of these viruses. I have in my service many patients with HTLV-1, HTLV-2, and HIV, for instance. When we have 2 viral infections affecting the same individual, we can have some potential outcomes. First, disease progression from one side to other, or most of the cases neutral, or at least we believe they are neutral because we don't know exactly what happened in this case. But would be maybe protection. Well, in the case of the HTLV-1 infection, we have 2 papers from Japan showing a protective effect of HTLV-1, but against the bacteria. They just realized that patients with HTLV-1 has less chance to be infected by H. pylori and also have less gastric cancer. And the probable explanation for this is the environment, the gastric environment is modified by the infection and promotes a very strong pro-inflammatory response that do not allow the growing of Helicobacter pylori at the site. Well, what do we know about both the viruses? We know that HIV infection has very active replication, intense cytopathic effect that leads to lymphocyte depletion, dystrophic for T lymphocytes, and most of the patients will have a clinical disease at any point of the infection. On the other side, the HTLV-1 infection is also tropic for T lymphocytes. It stimulates lymphoproliferation, the opposite of HIV. It, basically, through the increasing in the IL-2 production, and we're going to see clinical disease in a minority of patients. It is some doubt about that because some results from our colleagues in Salvador show that the potential clinical presentation is wider than those classical associated with the virus. It means ATL, MTSP, uveitis, and their effective dermatitis, myopathy, and many immunological disturbances that are not so clear when you look at the co-infected patients. Some years ago, Vefa Franchini, one of the main researchers in this area, she's an editor at HTLV, asked me to make a review on co-infection. And my first find was this: all of the evidence we have about HTLV-2 show no interference with HIV, and in some cases suggest that the infection could be protective. One of the potential explanations, HTLV-2 is tropic for CD8, HTLV-1 is tropic for CD4. So basically the role of these two subpopulations are quite different, and it could explain why HTLV-2 is not associated with any clinical disease. But we have at least one publication from Brazil, the guys from Fiocruz, that detected worse neurological outcomes in patients co-infected by HIV and HTLV-1. In this case, it means HIV is not affected by HTLV-2, but HTLV-2 can affect HIV. Okay, let's look at the HIV-HTLV-1 co-infection. As I said, HTLV-1 is tropic for CD4 cells, increased CD4 cells frequency, but they are dysfunctional CD4. I'm gonna show you later. And there was some evidence from Sobeski in 1998 showing that probably there was worse outcomes in HIV patients. We have two studies trying to identify the characteristics population, but first we try to see what would be the immune response of patients co-infected by HIV compared to HTLV-1 alone or HIV alone. And you could see that IL-2, gamma interferon, IL-4, and IL-6 were higher in co-infected patients, while IL-10 was less frequently expressed. So it means it seems that there is a predominance of the HTLV-1 modulation on HIV, because HIV usually make a deviation to Th2 profile, while HTLV-1 do the opposite, a strong Th1 immune response. And one of the first evidence we could see that in our group that co-infection could modify some clinical disease was this one. In 2002, looking at we are studying patients co-infected by HIV, HTLV-1, and one of our collaborators in the lab, Sergio Pedroso, told me, well, why most of the patients we are studying are present some skin lesions. We try to look at this patient, all of them were presenting crusted scabies, Norwegian scabies, the worst form of scabies. And when we try to identify what's happening in general, we select about 2 years of follow-up of all the patients with scabies in our service, and you could see that the patients with crustal scabies were basically co-infected by HIV, HTLV-1, and severe scabies was associated by HTLV-1, and no of these forms were associated with HIV alone. It means that HTLV-1 probably was the cause of severe scabies, and here we see in the left the crustal form of the disease, and this we considered severe form that affected over 80% of the body surface. So what would be the outcomes, the impact on clinical outcomes? There is many controversial data in the literature. Most of the cohort studies showing a higher mortality for co-infected patients, but they do not clarify what factors were involved. And we hypothesize that a delay starting antiretroviral therapy could be the explanation for the higher mortality rate. Because most of you are younger to know that, but when we begin to treat HIV, we treat it according to CD4. And there was no advantage to start early in the course of disease. We wait the patient reach a CD4 below 200 cells. And what happened with the HTLV-1? Artificially increased the CD4. So we look at the patient with AIDS, but with 400 CD4. So we didn't treat them and they died. That was our hypothesis to explain that. We confirmed it later. In 2001, we looked at the co-infection and survival for co-infection in mono-infected patients. In blue, you will see that only HIV has a higher survival probability than patients co-infected by HTLV-1. Well, it's confirmed that the preliminary studies from Sobieski and Martin French Guiana that show the same. And some years later, we look at the children infected by HIV and co-infected by HTLV-1, and we see the same profile. We can see that the curves are very similar. Children co-infected by HTLV-1 died faster than those infected by only HIV. It was the opposite that an American group, Mark Beeke at that time working in New Orleans in Tulane, published this in Clinical Infectious Disease, showing that there was a protective effect of HTLV-1 and HTLV-2 on infected patients. But I sent a letter questioning some method because they made a basic mistake. They paired the patients by CD4, but CD4 is an outcome variable. It should not be used to pair the patient at baseline. And in addition, they only looked at the patients in a database. They didn't see real patients. So I talked to Mark later, and he agreed with all my criticism, and we dismissed this as a strong evidence of protection by HTLV-1. And then we made this study in Bahia with 132 patients, 30 of them co-infected. They have a similar risk of progression during the follow-up, was 1.5 year only the follow-up. All of them showed higher lymphocyte and CD4 count in co-infected patients, but not in asymptomatic patients. So it was the first evidence that our hypothesis was right. And we find a much higher frequency of Strongyloides staphylococcus parasitism, almost 9 times more than observed in HIV. And we could prove in this, demonstrate in this study that the delay in the introduction of retroviral drugs for co-infected patients, they have only a 23% chance of receiving retroviral therapy if they have co-infection compared to those infected by HTLV-1 or HIV-1 alone. So a couple of years ago, we performed this larger study, almost 300 patients. They were matched by age and HIV diagnosis. We never know when they got infected by HIV. And we look at the survival. The two curves at the top of the figure show the survival time for patients with good HIV control. Stable patient on stable therapy and undetectable viral load for HIV had a similar survival time, regardless they have HTLV-1 or not. However, when we look at the patient with failing antiretroviral therapy for HIV, we see that HTLV-1 make a very important difference. There was a significant difference between co-infected and non-infected. It seems that in this case, probably we have a combination of factors that make the prognosis worse in the patients that are co-infected and do not control HIV. So it was a clear demonstration that there is a real interaction basically among the patients that were not properly treated. And if you look at the CD4 count, according to HTLV status, you have a positive in this left side and negative here. Look at the comparison of CD4 for the dead and alive people. Basically the same in the positive group, but quite different in the negative one. It showed that it demonstrates that HTLV-1 increased CD4, dysfunctional CD4. They didn't work, but it seems the guy is in good shape, 400 CD4, that's nice, but they died. AIDS with this CD4. So it was the demonstration that the hypothesis that CD4 was maybe probably the main confusional factor in this evaluation of co-infection. Let's move to HCV, another important virus. What happened in HTLV-1 co-infecting this patient? There are some previous studies at the beginning of this century showing that HTLV-1 could provide some evidence of immune dysfunction that could worsen the prognosis of co-infected patient HTLV-1 and HCV, mainly from Japanese groups. However, in 2013, we did this simple study in our group, just looking for this serological prevalence of hepatitis B and C. And you see that HIV, we have a 13% of hepatitis C, 4% in the HLV group. And when we have a HIV and HLV group, it increased to 34%. No significant difference for hepatitis B and C, but it was most impressive when you look at the viremia, HCV viremia, not HIV. Co-infection by HIV and HCV, 100% of the patients who were viremic. If they got HLV together, only 73%. And without HIV, it decreased to half of the patients only presenting viremia. It means it seems that the HTLV-1 increased the rate of spontaneous clearance of HCV co-infected patients. So when you look at the other Japanese guy, that co-infection decreases spontaneous clearance. But we did this 2012, this study showing that co-infection by HTLV-1 seems to decrease the level of liver fibrosis after adjustment for CD4 count. And we look at this, that's a summary of the work. If you have HIV and the HTLV-1, you have a significantly higher probability of spontaneous clearance of HCV. And if you have only HTLV, again, it's marginal difference, but it was still significant. So HTLV-1, in our experience, improved the prognosis of HCV co-infection because people seems to be more able to spontaneously clear the infection. And it is in accordance with the previous data we showed, previous slides. We try to look at the immune response in this case, and we selected 3 patients well characterized with HCV clearance, co-infected by triple infection, and who clear HCV spontaneously. Another group which HCV triple infected, but with still active HCV infection, and the last group was HIV-HCV without HTLV-1. And you see that most of the, except for runs, all the other pro-inflammatory cytokine at much higher concentration in the people that clear the HCV infection without treatment. And the lower level were seen in the patients without HTLV-1. It means in this case, HTLV-1 can probably by the immunomodulation it promotes, it can help patient with co-infection by HCV and HIV. In conclusion, this study showed that the HTLV co-infection can modify the immune response and clinical presentation of some viral co-infections. We do not understand the complete factors involved in this interaction, basically because there is so many studies focused on co-infection and the methods are very heterogeneous, and we cannot use this to explain this difference. And in addition, we believe that some other, especially herpesvirus, can be involved in this process. We have some unpublished evidence that having EBV, HHV8, or HBV on board can modify this response. Well, let's move to the treatment of HTLV-1 infection. The main problems, we have no specific treatment so far, almost 50 years after the virus discovery. And is a big problem everywhere, but for us, it's more important. We have no funding for this area. And the previous studies on using antivirals had a small sample size, small, short follow-up, and were not able to provide any evidence that could work. And there is a paradigm that HTLV-1 is replicated basically by clonality. I ever questioned this paradigm. If you look at the viral cycle of HTLV-1, it looks like basically the same of you see in HIV. You have a binding, entry, translation, integration, and budding and maturation by protease. So many potential targets for antiviral therapy. Well, the mechanism of HTLV-1, according to the current paradigm, is basically some protein established by synapse between uninfected and infected cells. Another potential mechanism is the development of a cytoskeleton, making a conduit between the infected to non-infected cells, and the virus can escape the immune response and infect the cells by cell-to-cell contact. They also sometimes promoted the biofilm that cover the infected, non-infected cell that allows the virus to replicate below this cover and without being affected by the immune response. And finally, the dendritic cells can act as a bad guy in this, because when they present antigen to the CD4, they also present the whole virus, promoting the infection. And by clonality, they also can increase the viral proliferation. Well, and again, in the same paradigm, you have HTLV-1 integrates the DNA host in a permanent way and begin to be replicated in the first phase, in the first month of infection. However, after this phase, we have a suppression of TAX protein, a very important protein involved in viral replication, by HBZ, that's another protein that downregulate TAX and make an important role in the cancer development. And finally, the patient with established viral infection would be silent, no active replication, but clonality would be the main application form for this at this stage. I question this sequence. I believe that there is an active application that remains over time, even the chronic infection. And the current paradigm is we have a clonal infection that is not able to be reached by antiretroviral drugs because there is no active replication. However, in my perspective, we could, there is a ongoing active replication that could be blocked by proper antiretroviral therapy. And it's very important because you can see in this slide that provider load is an important predictive factor for some disease. MTSP, you see that the provider load is much higher than that observed in asymptomatic carrier. And if you look at the ATL, it's much higher than MTSP. So provider load is one of the single immune markers you have, a biomarker to evaluate the risk of disease progression. There was some previous evidence that support the use of integrase inhibitor. As you know, integrase inhibitor aims to revolutionize the HIV treatment because, and today they are the most widely used class of drugs. And in Barsky and collaborators show that they are active in vivo and in vitro against HIV. And a small trial using Haltegravir also, it was not able to clearly demonstrate a clinical benefit, but they identified that could be have some benefit on decreasing provider load. A couple of months ago, the guys from an Australian group presented this very nice work showing that humanizing mice could, in the lab, show a complete evolution for ATL. And most important, they treated the mice with antiretroviral. They could avoid the infection on new cells. Antiretrovirals act as PrEP. And they also, using antiretrovirals and MCL1 inhibitors, were able to mitigate the infection, eliminate the infection in some cells. Moreover, they show that the use of dolutegravir was effective in reducing provider load as well as with tenofovir. And combining the two drugs were more effective in providing decreasing provider load. Taking advantage that we have some well-characterized population of co-infected patients, we developed this proof of concept using HIV, HTLV co-infected patients because they were already under, most of them under antiretroviral therapy. We selected 61 cases, and after some exclusion, 44 were eligible to enter the study, and we paired them with 44 affected by HTLV-1 only, and paired by age and sex. And we used some cutoffs to define the activity. Provider load was categorized by median, IQR 75, and detectable and undetectable. And we found that in this propensity score, that dolutegravir used for longer than 6 months was able to decrease provider load for the whole population. And we have also a significant difference. The proportion of patients with provider load below the median and below the IQR 75 was higher in the patients under dolutegravir compared to the non-treated ones. And also, the proportion of undetectable provider load was higher, significantly higher among patients co-infected and receiving dolutegravir. The conclusion was use of dolutegravir for at least 6 months was significantly associated with decreasing provider load in all scenarios we tested. And this findings challenged the current concept that the HTLV-1 replication occurs predominantly by clonality. We could not explain this if you don't have an effective action of the antiretroviral drug. At the same time, we conducted this pilot trial, phase 2 controlled randomized open label study comparing dolutegravir 50 milligrams daily versus vitamin C. And they were followed by 1 year. And after 1 year, patients on vitamin C arm could move to dolutegravir and be followed for additional 48 weeks. And what we could see at the first year, the follow-up, a significant decrease in provider load in the patients using dolutegravir, but no change in vitamin C group. And some impact, beneficial impact on clinical findings. Spasticity is a main characteristic of MTSP. And some other functional and neurological symptoms. For instance, altered light touch sensation, prick sensation were better in the patients treated with dolutegravir, but not in vitamin C. And also some very important impact in functional independence. The domains, the motor domains and cognitive domains were significantly better in patients treated with dolutegravir compared to vitamin C. And we try to look at the improvement. The clinical improvement was associated with the provider load reduction. In this hierarchical cluster, cluster 1 was patient that had lower provider load at the beginning, and they did not change at all. And cluster 2 were composed by patients with higher provider load that decreased over time. And the significance, significant change observed in clinical symptoms were present only in cluster 2. And this was a clear demonstration that decreasing provider load was a reason for the improvement of this group of patients. And finally, I evaluated this patient after 2 years of follow-up. And here we have two clusters again. The cluster at the top of the figure are composed by the patient that received dolutegravir for 2 years. And the lower cluster is composed by patients that received vitamin C for 1 year and moved to dolutegravir after this period of time, as you can see in the diagram. So when you look at the variation, the delta provider load between the several time points of the study, there is no difference in cluster 2. And but in cluster 3, the top of the figure, you can see that even after stopping therapy, 6 months after stopping therapy, we still have a provider load below that observed in the baseline for that group. The patient that were treated by only 1 year did not present. They did not reach the same values, but the difference was was not significant. But there is a clear evidence that people treated for a longer time can have more benefits, and they can persist for even after interruption of the therapy. And here you have the dynamics of the kinetics of the viral modification. You see here in the red, the green, the patient that used dolutegravir for 2 years. Only one patient had a rebound after interruption of therapy, 2 years of treatment. That one is the top of the figure. Most of them remained with provider load below the levels observed at baseline. And there is one lady in this group that was treated and stopped therapy for almost 4 years ago. And she is still undetectable, even after 3.5 years without therapy. On the other hand, if you look at the patient that were treated only for 1 year, you see there are very diverse picture, because the viral load increasing in many of them, and even considering that some of them kept the viral loading below the levels observed at that baseline, the overall results are quite different from the treated for 2 years. We also observed some very specific differences in cytokine profiles. You see in green again, dolutegravir, TNF-alpha did not change over time, but IL-10, IL-6, IL-4, IL-2, gamma interferon, IP-10, and BP1 alpha all decrease with treatment of dolutegravir, but most of them increase in the group that received vitamin C. It was after 1 year of treatment. And when you look at the cytokine network, the relationship between the different cytokines, you can see that at the beginning, at the baseline, both group has a very disorganized cytokine expression and disbalanced pattern. But after 6 months and 1 year, dolutegravir presents a more organized, and then all that disbalancing is attenuated over time. But vitamin C group continue with the same profile observed, the same pattern observed at the beginning. So it means that dolutegravir is able to modulate decreasing provider load, probably promotes a positive modulation in terms of cytokine expression and correcting some dysfunction that we observe in untreated patients. So dolutegravir significantly reduces HTLV's provider load, sustainable over 1 year, promoting improvement in several clinical findings, but some patients did not respond to dolutegravir. We list 3 potential explanations. Adherence, very unlikely, because these patients are evident for anything that could be used for treatment, because there is no treatment in the progressive disease. So resistance, also likely, because HTLV-1 is a stable virus. The genomic variation is very small compared to HIV, for instance. Even for HIV, using dolutegravir for 1 year, rarely in patients failing therapy is able to promote some the emergence of a resistance mutation. So our hypothesis is this case that not respond to treatment probably a real, basically clonal replication predominance. And now I am going to show some data provided by Bob here with some this patient using single cell RNA sequencing. And the first of all, one unexpected finding that was a majority of monocytes expressing some detectable genes in MTSP patients, and no difference compared to naive T cells, memory, CD8, or B cells. And the results showed 5 upregulated genes and 9 downregulated genes. And some of the immune activation signatures observed in MTSP patients at baseline were clearly attenuated after 96 weeks of treatment with dolutegravir. And the distinct pro-inflammatory gene signature also seen at baseline, again, was partially reversed by dolutegravir treatment of 2 years. We see the same profile for chemokines and genes, inflammation modulator genes suppressed at baseline, but that appears after treatment. And the deficit in genes involved in chemotaxis is also partially corrected after 2 years of dolutegravir treatment. So we have some clear significance and potential implication of this finding. There is active replication of HLV, contrary to the paradigm that predominance of clonality. So we believe that use of antiretrovirus is possible in patients with active replication. Clinical and virological response may vary between patients, and the potential explanation for this, as I said, is predominance of clonal replication in those that fail to respond to dolutegravir. We need to define criteria for the use of antiretroviral. We are talking to the Brazilian Ministry of Health to propose dolutegravir use for be offered to HLV patients. And they said, well, which patients are you going to treat? Because most of them will be free of disease-free for life. Okay, maybe trying to detect evidence of persistent ongoing viral replication. We are trying to see the LTR signals in this patient. Maybe we could just treat this patient, see after 6 months if there was any decrease in provider load, significant decrease. If yes, okay, keep the antiviral for at least 2 years. And if not, okay, it's not working, probably no benefit is expected in this case. And we see also potential application in infection prevention as PrEP or PEP. And we clearly show that HTLV modulates gene expression. And we believe that antiretroviral treatment may restore the immune response, allowing patient to control the viral replication without the need of additional drugs or continued treatment for life, for instance. Well, in addition, HLV persistence was the current paradigm is thought to be driven by clonal expansion, but our results challenge this concept. And we believe that there is a mix of patients presented basically active replication, other patients presented basically clonality. And the transcription data reinforce that first, the role of monocytes in disease generation, and also suggest that treating this patient with antiretroviral can not only block viral replication, but also restore the immune response, making patients able to control the infection without the need of antiretroviral drugs. And an interesting side bystander effect of this trial was we have a very I would say that most of the guys in HIV area say that integrase inhibitors are associated with excessive weight gain. I do not see it in my clinic. I have 4,000 clinical under my clinic, and I see many, many patients for over 4 years. And I don't believe in that. We have some preliminary evidence showing that it depends on the CD4 at the starting of therapy. If you treat patients with CD4 below 200, they will gain more weight over time. But the patient treated with good CD4 at baseline, they did not gain any weight, and some of them lost weight. So it means that it could be better explained by a return to the health the patient treated with the antiretroviral. And this is the first study that treat patients without HIV with integrase inhibitor. And we perform bioimpedance from patient at beginning and after 2 years of follow-up. And there is no difference between body composition of patients with dolutegravir treated with dolutegravir or vitamin C. And the difference we've seen in two aspects was edema retention of water was higher in vitamin C, is bad. And also angle phase, it's a measure. I don't know nothing about bioimpedance, but the guy told me that it's a good sign. The angle phase was better in patients treated with dolutegravir. A conclusion that the opposite direction of the current concept on that. Finally, I thank Robbie, Arnold, Rick, Keith, all of you for inviting me for the to share this opportunity to share that these findings, and my lab team, one of them is here, Felice, and especially to the Brazilian Ministry of Health who provided me dolutegravir for treating these patients. Thank you very much for your attention.
Wonderful talk. I have so many questions, but I'm trying to keep it. So I'm very interested in the replication aspect of it. So the two ideas is that one, the virus hangs around the cell and persists. And so when you do the integrase inhibitors, it's actually preventing the integration event itself. And then the other idea is that it enters, it integrates into the host genome, and then that keeps replicating and sometimes leads to clonal propagation depending on the mutation. And then that's the clonal replication. Is there a correlation between how early you start using the integrase, the time of diagnosis, or
we have no chance to test this because we never know when people become infected by HTLV-1.
is there a screening protocol available in Brazil? Like
Yes, most of all pregnant women, for instance, are screened at that, even they follow up before delivery. And but it is not possible to know exactly. In HIV, we have usually you have if you look at the epidemiological history of the guys, you see a point when exposure turns on clinical acute AIDS, or a point that was the potential point of transmission. In HTLV-1, we never know, except in the case when the mother can be tested and we see that she is positive. In this case, we assume that breastfeeding was the route of transmission. So, but for adults, and we did a search for a study trying to estimate the prevalence of HTLV-1 in 6 regions in Brazil. Bobby participated in Prince, and the first difference between being negative or positive age. So older people are more likely to be positive than younger people. It means sexual transmission. And in this case, it's impossible to know. There is no, as far as I know, there is no evidence on acute HTLV-1 infection. I got some few cases the last year because some people call me from around the country for the treatment. In two cases, I could identify basically the estimated time of infection because that was in both cases two married women that divorced 5 years ago and were negative because they had some routine tests. And in next screening, they detected they were tested positive. And we could estimate that the infection occurred about 2-3 years before. But it's the only way. Regarding the integration, one at this point, we are just starting a new trial comparing dolutegravir and dolutegravir plus tenofovir, because in the study from the Australian guys, they showed that dolutegravir could improve the antiviral activity when combined with tenofovir or TAF. And if you look at the viral cycle, it seems attractive to target two different points, the reverse transcription and integration. But in the case of where you have already integrated DNA in the genome, we are looking if the dolutegravir can modify the integration site and if it could be associated with any particular mutation. But Felipe probably will provide some data in the next 2 months. But it's still a very open area because there is no previous evidence on that.
When do you start using the integrase inhibitor in patients? Like, I know you screen them and then you detect that they are positive, but is there a minimum clinical requirement to start them on integrase?
Yes, in this case, it was an exploratory trial. So we included asymptomatic patient because I said only decrease in provider load, and we include some symptomatic patient. But I did not include those in restricted to wheelchair, for instance, because we have to measure other, and there could be a confusion factor. We include the patient with any neurological symptom that was associated with HTLV-1 infection. In this new trial, I am admitting patients that are at wheelchair, but at least be able to walk 10 meters, even with help of support. But because we have many other, this patient with advanced disease has many other inflammatory conditions that can interfere in the immune analysis, for instance.
Carlos, I hadn't previously appreciated until you showed it at in Philly, the conference in Philly, your cluster analysis where patients that had high proviral load at baseline, those are the ones where dolutegravir where it's most effective versus patients at baseline that had low proviral load, you didn't really see too much variation in that. So is the thought there that those patients that had at baseline high proviral load, are those the ones where you get active HTLV replication versus the ones that are at baseline already minimal? It's probably clonal expansion in those patients.
Probably yes. And if you remember, I asked you about the data from the patients with transcriptional results, because I believe it will be very, very interesting subpopulation to look at closely about the immune modulation and the relationship with the decrease in provider load, because there is a clear difference between the two groups. And moreover, and I just realized when we look at the 96 weeks that 1 year was nice. We show some very improvement, but it's not enough. Probably we have at least to treat this patient for 2 years. Our results show that. Maybe more for 2 years for some patients. Maybe the next step would be to treat patients for 2 or 3 years, then stop and look at them again, and how many rebound, how many are controlled there.
And this theory about the integration, sites being different with the use of the integrase, it would be great, I think, to look at hybrid transcripts, post and viral, to see if that would kind of inform also and confirm this idea.
That's what we're trying to do.
I would love to talk more with all of you. We can set up a time. I'll talk to Bobby.
It was beautiful, Carlos. I guess one question that I have is, where do you think virus might be replicated? We know in HIV, for example, that there's this enormous replication in the gut early on, right? And I'm always been taken, and Pooja had asked us to write a review about the strongyloides issue, and in doing that, in sort of the questions arising with respect to why strongyloides is so high in HTLV-1, it sort of jumped out at me that no one's really looked, as far as I know, at HTLV in the gut and gut lymphoid tissue, which is half of the lymphoid tissue in the body. Do you have any thoughts about those related pieces?
We have a very, very scarce evidence on that. But regarding strongyloides, is one potential explanation. We have a high levels of IL-5 in these patients. So low level of IL-5. So they lost the protection against the parasites. And we have some patients with, I got one patient at the clinic he was a 35 years old man. He had a chronic weight loss. He weighed about like a boy, teenager, and he has an hemoglobin level of 6, median hemoglobin level. And because every time he comes to the hospital, and plenty, all the slides, plenty of larvae of strongyloides. And when I saw that, I tested for HTLV-1, was positive. So we treat and give the post-treatment prophylaxis with carbendazole. And he used it forever. That's okay. So maybe the strong Th1 response induced by HTLV-1 decreased the Th2 necessary to control the parasites. And the group of Edgar Carvalho tested a lot, and schistosomiasis also is very hard to treat in this patient because of this immune deficiency. So it's a side effect of the immune modulation, strong immune modulation toward Th1 profile that is promoted by HTLV-1. But I was just remember I talked about the CNS cells, and we had one case a couple of months ago. A patient has a paraparesis, very low provider load, but 400 copies of RNA in the CSF. So we have very low cells with integrated virus, but high provider load in the CSF. And it means there is probably many compartments that we can explore and see what happened, because probably are not the same. And on the other hand, if you look at the RNA in the blood, usually are undetectable levels. We are trying to optimize one PCR to detect RNA, because even if very low, if you maybe detection or non-detection could be a key to identify patients candidates to therapy.
Great talk, very insightful. I have a very quick question. The integrase inhibitor, do you think it has a specific role based on the disease that these patients are suffering from, considering ATLL, which has a high viral load compared to MTSP patients? Do you think the effect would be different, or will it be associated with toxicity in ATLL patients if the dose is increased in some way?
I believe that ATL would be the main target for antiviral therapy. And I have, again, a case I discussed with Bob. We probably will write this down in the next weeks when I have time. One patient that I follow for over 20 years. He was infected by a blood transfusion when he was 12. He's 66 now. And he developed a leukemia, ATL, smoldering form 7 years ago. And there is nothing to do. And he asked me, my friend, a colleague, I told him, okay, you can take AZT, because I had a very good experience with AZT in this case in the past. He begins to take AZT, but provider load is still 6,000. It's a high level provider load. And when we began this trial, he asked me, why not give me dolutegravir? Okay, we have some leftover dolutegravir, I give him. And he become undetectable in 3 months. And he is completing 3 years of follow-up, no virus at all, and stable disease. He already surpassed the estimated median survival time for smoldering forms. Is almost 80 years of follow-up without any manifestation, clinical manifestation of disease. So I believe if we see the levels of a provider load are very high in ATL, if you are able to block this virus, and in this case, it means if you look at the pathogens of NTL, you have a immortalized CD4, is the leukemic cells. It means probably only integration clonal, but they respond very well to dolutegravir. It means, okay, you have clonality, but probably the main application form of the device is active application. So
Oh, so we have a question online. Maybe that's the last question because we're running out of time, but I think Rick's asking, do you have any HTLV-2 infected patients? And is there any hopeful treatment or data for hairy cell leukemia?
it's very rare, and HTLV-1 was isolated from a patient with hairy cell leukemia, but it is not linked to hairy cell leukemia. So, and as far as I know, there is no relationship between the virus and this specific neoplasm, and treatment would not be advisable.
Well, thanks. I just had to ask, Carl. Thank you.
Yeah, thanks, Rick. Okay, well, with that, maybe we'll give a round of applause.
Fantastic. Thank you.